topic of today's discussion is management of borderline ovarian tumors. They are also known as tumors of low malignant potential or LMP. They were first described by Taylor and constitute around 10 to 15% of all epithelial ovarian neoplasms. So, among all the epithelial ovarian tumors, 10 to 15% tumors are borderline tumors. Okay, or also called as low malignant potential, tumors with low malignant potential. Borderline ovarian tumors are heterogeneous group of tumors often seen in younger women. They demonstrate higher proliferative activity when compared with the benign neoplasm, but they do not show stromal invasion. So what are the characteristics of borderline ovarian tumor? One, they are seen in younger patients. They have higher proliferative activity than the benign tumor, but they do not have a stromal invasion like malignant tumor. Okay, so many are only diagnosed after primary surgery has already taken place for presumed benign lesion. So most of the time they present as a benign tumor, the surgery is carried out and then it comes a borderline. Okay, so in that particular case we come to know the diagnosis is retrospective. So the subsequent management often then causes confusion. So complete surgical staging is the cornerstone of the management, but conservative surgery is an acceptable alternative in those who are keen to retain their fertility. So once you have done a conservative surgery and if your histopathology comes as a borderline tumor, then you have to carry out the complete surgical staging. Okay, and conservative surgery if the patient is wants the retention of the fertility. Okay, the role of long-term follow-up is controversial in patients with borderline tumor. So typically these are seen in younger group patients. Their invasive as compared to their invasive counterparts and often diagnosed at earlier stage, resulting in excellent prognosis, and survival rates are better than those for women with frankly malignant ovarian tumors. The 5-year survival rate for stage 1 borderline ovarian tumors is 95 to 97%, and stage 3 disease it is around 50 to 86%. The 10-year survival rate is also high, 70 to 80%. So sometimes they ask you about the, especially in part 2 they ask you about the survival rate. Okay, so 5-year survival rate for a borderline stage 1 tumor it is 95 to 97%. For stage 3 it is 50 to 86%, and 10-year survival rate is 70 to 80%. What are the risk factors? Younger women are more likely to have borderline tumors compared with the older women. Parous women have a reduced risk of developing borderline ovarian tumors compared with the nulliparous women. Lactation is found to be protective. These risk factors are similar to those recognized for invasive ovarian cancer. Unlike invasive ovarian cancer, oral contraceptive is not protective against the development of borderline ovarian tumors. Remember, this is also one of the another feature about the oral contraceptive. They will what you can say for borderline tumor, their role is not protective against the development of the borderline ovarian tumors. So unlike invasive ovarian tumors, OC pill use is not protective against the development of borderline ovarian tumors. There is no evidence that women with mutations of BRCA gene mutation, there is no evidence for the borderline ovarian cancer unlike invasive cancer. So even BRCA gene mutation, there is no evidence for borderline ovarian cancer. This BRCA gene mutation will lead to ovarian cancer, but they will lead to invasive cancer and not the borderline ovarian cancer. Is it clear? So
Yes, sir.
when we talk about the etiology, either protective or oncogenesis, the OC pills are not protective for the borderline tumor, and even the BRCA gene mutation will lead to sporadic cancer. Okay. Then another thing is molecular studies that are at least two distinct forms of ovarian cancer. One is a high grade serous cancer associated with P53 mutation that leads to invasive neoplasm, and low grade tumors, that is borderline ovarian tumors, that has got a mutation of BRAF and CRAS pathway. So this mutation pathway they are also different. For high grade serous tumors it is a P53 mutation, and for borderline tumor they have a BRAF and CRAS mutation. This is also SBA. Okay, high grade serous cancers have show dash dash mutation, it is a P53 mutation, and for low grade or borderline tumor you have mutations of BRAF and CRAS pathway. Okay, Now, histological classification of borderline ovarian tumors. You have serous, that is, they account for 50%. Then mucinous, they account for 46%, and rest others, that is endometrioid, clear cell, Brenner, and mixed, they account for 4% of tumors. So histologically, if you see these borderline tumors, mainly they are epithelial type, accounting for around 50% of tumors. Okay, and those who are mucinous, they account for 46%, and they are also of two types. One is intestinal and another is endocervical. Okay, in that also intestinal is around 85% and endocervical is around 15%. Okay, then histological features: mixed, endometrioid, clear cell, Brenner, etc. They account for 4% only. Epithelial cellular proliferation greater than that seen in benign tumors. So there is a high proliferation in this tumor. Borderline ovarian tumors have a stratified epithelium with varying degrees of nuclear atypia and increased mitotic activity. They lack stromal invasion that distinguishes them from invasive carcinomas. So high proliferative activity but no invasion. That is one of the characteristic of borderline ovarian tumor. Now clinical features: pelvic pain, bloating, dyspareunia, then menstrual irregularities, pressure symptoms such as frequency of micturition, constipation, etc. Investigations: CA125 will be raised in around 70% of serous and 30% of mucinous tumors, and CA199 is raised in mucinous borderline tumor. Okay, so CA199 is for mucinous borderline tumor. Okay, then investigations: we can carry out TVS. They will give us the cyst diameter, thickness, regularity of the cyst wall, complexity, that is solid areas, septa, then intracystic papillary projections, and presence of ascites. Color Doppler is investigation demonstrates intracystic blood flow and is sensitive in differentiating malignancies from benign tumors. MRI will tell about the unilocular cyst, minimally septate cyst with papillary projections, and markedly septate lesions with plaque-like excrescences to solid lesions with exophytic papillary projections can be seen on MRI. So MRI will also tell us these particular, whether there is a solid component or unilocular or multilocular. These things we can come to know on MRI. Now coming to the management of borderline tumors, it depends on the age of the woman, the stage of the disease, the potential desire for pregnancy, and the nature of peritoneal implants. The standard management is similar to invasive ovarian cancer: accurate staging and cytoreductive surgery wherever appropriate. So standard management is similar to invasive cancer: accurate staging and cytoreductive surgery wherever appropriate. Where possible, ovarian tumor should be subjected to frozen section analysis. Okay, if the frozen section is reported as a borderline for older women with no fertility concern, a complete staging should be undertaken. So ultimately you have to do the complete staging, provided the woman is older and there is no desire for the fertility. Okay, so what we carry out: exploration of the entire abdominal cavity with peritoneal washings, total abdominal hysterectomy, bilateral salpingo-oophorectomy with infracolic omentectomy, and appendicectomy in cases of mucinous tumors. Okay, one third cases reported as borderline at frozen section are later reclassified as an invasive tumor also. So one third patients who are on frozen, they are diagnosed as a borderline, but later on final histopathology may come as a invasive tumors. Okay, so borderline tumor is diagnosed on histology after primary surgery. You have to refer these patients to regional cancer center. Then you have to carry out the discussion in the MDT meeting. Okay, then further management is planned as per the MDT discussion, considering the histology, grade, stage, DNA haploid status, and fertility preferences and completeness of the primary surgery. So the role of restaging and completion surgery: decision to undertake the further surgery will largely determined by the three factors. One is what is the histological subtype of borderline ovarian tumor. Second, what is the primary surgery, whether how complete the primary surgery was, and third, the fertility desire of the woman. So when you have got a diagnosis of borderline ovarian tumor retrospectively, you have to refer these patients to regional cancer center. Then there will be MDT meeting, that is multidisciplinary team meeting, and they will take into account the histology, the grade, the stage, the DNA blood. All these factors will be taken into account, and patient related factors such as their fertility concern and what was the primary surgery, how complete the primary surgery was, and then the further decision will be taken. Okay, so borderline ovarian tumors with invasive disease with invasive implants has got a high risk of recurrence compared with those with non-invasive implants. Okay, so the implants are of two types. One is invasive implants and the non-invasive implants. If the implants are invasive, the risk of recurrence is 31%. If the implants are non-invasive, there is a 21% risk of recurrence. Okay. The presence of DNA ploidy is an independent risk factor associated with 19-fold increase in the subsequent risk of dying when compared with the diploid tumors. Okay, so if there is a DNA aneuploidy, again there is a risk of poor prognosis. Okay, restaging may be warranted for women with micropapillary tumors, invasive implants, DNA aneuploidy, and those with no fertility concern. Then you have to go for restaging of these patients. Okay, the role of conservative surgery and subsequent fertility. Conservative surgery is an alternative for women with early stage disease and keen for fertility. Counseling regarding the risk of recurrence and subsequent fertility is essential. Okay, so conservative surgery, you can think of patients who are young and desiring fertility. Okay, conservative surgery is defined as a surgery with complete staging but with preservation of the uterus and at least part of one ovary to preserve the fertility. So conservative surgery is again a there is complete staging you have to do, but you have to preserve the uterus and at least part of one ovary. Okay, the two common options are, one what you can do is a cystectomy, and second what you can do is a unilateral salpingo-oophorectomy with or without infracolic omentectomy and peritoneal washing. So you will always take the peritoneal washing. You may carry out the infracolic omentectomy, and surgery may be cystectomy or unilateral salpingo-oophorectomy if you want to preserve the fertility of the patient. So systematic biopsies of a macroscopically normal contralateral ovary are not required. So if opposite ovary is normal, then additional biopsy is not required. Okay. Then what are the relapse rate? So if you carry out cystectomy only, then there is a high chance of relapse, around 12 to 58%. If you carry out salpingo-oophorectomy, there is a relatively less, 0 to 20% chance of relapse. But if you do the radical surgery, okay, that is everything, TH, BSO, omentectomy, okay, peritoneal washings are taken, then the risk of relapse is less, around 2.5 to 5.7%. There may be late recurrences, and the importance of careful long-term follow-up needs to be stressed. However, most recurrent disease is of borderline type, which is easily resectable and associated with excellent prognosis. So even if there is a recurrence, the recurrence is of borderline type only, and they have got a good prognosis. What is the role of laparoscopy? There is no clear evidence for laparoscopy in borderline ovarian tumor, okay, in surgical management. Staging and treatment of borderline ovarian tumor should be performed by midline laparotomy. What is the role of chemotherapy? There is no role of adjuvant chemotherapy which is demonstrated for borderline ovarian tumors. Okay. Now look at this particular chart. So if you have got a borderline ovarian tumor, then you will refer these patients to cancer center. Then you will take into account the patient's wishes to for the fertility. If they want to retain the fertility, and if it is an early stage disease, we can go ahead with a conservative surgery. If it is an advanced stage and invasive implants are invasive, then we will complete the surgery and keep the patient for follow-up. Okay, if it is a non-invasive implant, then we might go for conservative surgery and close follow-up. Okay, and if the patient does not desire fertility, then complete surgery and close follow-up is required. So this particular, have you understood that first thing, you have to refer these patients to cancer center. You have to take into account the fertility desire of the patient. If there is no desire, directly you will go for radical surgery or complete surgery and close follow-up. And otherwise, you will take into account the fertility status and the stage of the disease. Okay, and then you will go for conservative surgery. So suggested follow-up, risk of recurrence varies from 0 to 58% depending upon the histological type of borderline ovarian tumor and extent of primary surgery. Incidence of invasive disease at recurrence varies from 8 to 73%, and follow-up is for every 3 months for first 2 years, then 6 monthly for another 2 years, and then annually thereafter. Okay, So that is how the follow-up is for total 5 years, 3 monthly for 2 years, then 6 monthly for 2 years, then annually thereafter. Okay, so that finishes the borderline ovarian tumor. Thank you.